Welcome, everybody. We'll just wait a few more minutes while we have more people logging on. A couple of minutes till we start. I'll just give it another minute or so. All right, well, I think we might begin. Good morning, everybody. It's my pleasure to welcome you to this fourth and last of our NeuRAtalks webinar series for 2021. I'm Carole Renouf. I'm the Executive Director of Neuro Foundation, and thank you very much for joining us. We're going to be holding another series of NeuRAtalks next year. We'll be sending you a follow-up email after this one to alert you to this and invite you to once again join us and share the registration link with family, friends, and colleagues. I'll aim to structure this session so that I have around 25 minutes with our panelists, followed by around 20 minutes for you to ask questions of them. Please don't wait till I throw the floor open for your questions. Post them in the Q&A feature, not the chat box, that's disabled. And please don't raise your virtual hand. Just use the Q&A, although we won't pick up your questions till later in the piece. Now to the topic of today. Schizophrenia may be expressed in just one word, but it is in fact a complex and diverse behavioral and cognitive syndrome, originating from disruption of brain development and function by an equally complex and diverse mix of genetic and environmental factors. This is what causes schizophrenia to have such a drastic impact on those who experience it both directly and indirectly. And there will be many in our audience today who know this, including myself within my family. But this is also what causes schizophrenia to be so formidable for research to unpack. While drug treatments to manage schizophrenia have not advanced much for over 50 years, we're going to talk about where are we now with research. Let's find out. Our first panelist is a University of New South Wales professor, Cyndi Shannon Weickert. Cyndi is the New South Wales Chair in Schizophrenia Research and also runs a lab in the US at Upstate Medical University. Something you may not know is this year Cyndi was awarded the Outstanding Translational Research Award by the Schizophrenia Research International Society for moving her fundamental discoveries in schizophrenia brains into clinical trials. She has been working on schizophrenia for over 30 years and has published over 270 articles in the field. So Cyndi, your research program investigates the pathophysiology of events in the brains of people with schizophrenia, often using post-mortem tissue. There are lots of different things happening in those brains. What are a couple of the most significant and why?
Yes, so the biggest breakthrough that I've had in my career is that finding cells that are supposed to be circulating in the blood are actually in the brains of people that suffer from schizophrenia. And these immune cells are not the friendly type, they're the hostile type. And we think that these immune cells could be entering the brain and triggering symptoms. And importantly, we found that it's only about half the people with schizophrenia that have these increased immune cells in their brain.
Okay, so the aim of your research program is obviously to translate your discoveries into novel treatments for schizophrenia. So what are some of the possible new alternatives for treatment?
Yeah, so along with these immune cells, there comes a cytokine storm, and there becomes tissue damaging effects from inflammation. So this means that we have an opportunity in the field to repurpose drugs that have been used to target inflammation, called anti-inflammatories, to use in the treatment of people with schizophrenia. Now, this has been trialed before, but it's not been successful. And we think we have a novel approach to clinical trials, and that is identifying beforehand who's in an inflamed state and selecting those for the anti-inflammatory instead of giving it to everybody with schizophrenia, basically using their biology to select those people that we think the anti-inflammatories are going to be of the most benefit.
So a much more personalized use of medicine.
Yes, and repurposing drugs that we already know are going to be safe in the human population are relatively safe.
Okay, and you've got a schizophrenia summit coming up this month, actually, bringing together scientists across New South Wales to share the latest findings. What do you expect to accomplish there?
Yeah, well, what's really great is we have leaders in schizophrenia research from Wollongong, Newcastle, Western Sydney, and here at Neura coming together to share their knowledge gains over the last year, to support early career research scientists, to give them a leg up, to help them become academic faculty and make a transition to an independent scientist, or for students to actually have opportunities to train in other people's laboratories or attend international meetings. We hope to develop collaborations and find some projects that we can work on together going forward.
Sounds great. I think this next concept that we're going to discuss is really interesting. I've heard you speak about the need for studies which measure the person with schizophrenia over time to try to determine if inflammation associated with schizophrenia flares up and then subsides within the same person. And I know you said you would expect neuroinflammation in schizophrenia to remit and relapse like multiple sclerosis. What implications would this have in terms of management?
Yeah, it's a very important question because if it is an inflammatory condition, that means everybody isn't going to be in an acute state of inflammation at the same time. So while I said we find 50% or about half the people that have inflammation in the brain or in the body at any one snapshot in time, it may be that 100% of people with schizophrenia have inflammation. It's just that at the moment we look, we only detect it in half. So the implications is it's really important to get the timing of the treatment correct and to try to understand how inflammation changes over the course of the illness. So in very early stages, there might be one way to treat the inflammation. And then as the stages evolve in the disease, we might be looking at a different type of an inflammatory treatment. And the most recent research that I'm doing suggests that while there's about half the people that are inflamed at any one time, they may not all have the same type of inflammation, that there may be subtypes within subtypes. So that again goes to show that we need to be very careful about selecting the correct anti-inflammatory treatment for the right person.
Yeah, because current treatments are a bit of a blunt instrument, aren't they? So I think what I hear you saying is the implications of that remit and relapse theory, right, are that the person with schizophrenia doesn't need necessarily the same treatment in the same dosage all the way through.
Yeah, perhaps not. And I think what's interesting is when we look at the individuals that are taking the mental health intensive care unit, there are even a higher percentage of those that are inflamed and to a greater extent. So that suggests that when people are acutely psychotic, they have a real disturbance in their inflammatory system. So those may be the people that need the most help.
Yeah, that makes sense. Okay, and I know in another piece of good news, you just recently secured a prestigious investigator grant from the National Health and Medical Research Council. What work are you going to focus that funding on?
Yeah, thanks, Carole. That's a real honor to be selected for that award by my colleagues. I'm very honored to have that. The work that I'm planning on doing is addressing the question of the nature of these immune cells. So immune cells, when they enter the brain, can be of two types. They can either be harmful or helpful. And like I said, we have evidence that the balance is tipped towards the harmful type. But it could be that some of those are also there to aid in tissue repair and to be neuroprotective, or even to fight against possible infections in the brain. So we want to really try to determine, how many of each different type are there. So drill down a little bit further on the actual type of immune cell and understand the balance of the immune cells, because what I'm proposing in clinical trials is to block immune cell entry into the brain. And I want to know the extent to which that's going to bring about clinical benefit for those suffering from schizophrenia, but I also don't want to block immune cells that are helpful from getting into the brain. So I need to determine that piece first and then go forward with the clinical trials.
Thank you. I'm sure we're going to talk more about this later. I'll move on now to Dr. Adam Walker, who is a research fellow at Neura and leader of the immunopsychiatry lab. Adam completed his studies in the States, initially here at the University of Newcastle, then in the States at the University of Illinois and Texas, and worked at Monash University before coming to Neura. Adam, how is your research complementary but different to Cyndi's?
Hi, so we're both very interested in how the immune system may hijack the brain to cause symptoms of schizophrenia, but I like to think of Cyndi as a detective who arrives at the crime scene, in her case, the blood or postmortem brains of individuals with schizophrenia, and tries to figure out what happened. And my lab is a little bit more like the crime scene technicians, where we try to figure out how it happened. We recreate the crime scene using cellular and animal models and try to figure out the weapons used by the immune system on the brain. And of course, if we do that, we can figure out ways to try and defend the brain from attack.
I like it. So you're very CSI.
Very CSI, right?
Very on trend. Okay. And you also adopt, I think, multiple ways of probing the immune system to understand how the symptoms and behaviors of schizophrenia occur, and thus how we could potentially turn some of these off. Can you walk us through an example?
Yeah, so there can be differences in how the immune system is activated, the timing and duration of events, in addition to the pathways through which inflammation in the body can reach the brain. So we tailor the way that we activate the immune system depending on the research question that we have. So one example is that we've used models of bacterial infection to help us dissociate the timing of events. So in the case of depression, which is highly comorbid with schizophrenia, we're able to see the change from adaptive responses to being sick into maladaptive long-term depression. And in doing so, we've identified a pathway that is activated called the kynurenine pathway. It produces neurotoxic metabolites in the brain. And we've been able to identify pharmacological treatments that may be able to remediate that, which have progressed into clinical trials led in the US. So that's one example.
Thank you. And I know you also adopt what's called a transdiagnostic approach, looking at what is similar in other conditions to schizophrenia, in hopes that therapies that work for one might be adapted for the other. Autism is one example. Can you expand on that?
Yeah, so as you mentioned, we haven't made much progress in the treatment of schizophrenia. And one reason is that there may have been a tendency by some to really treat it as an entirely unique disorder, whereas in fact there are similarities with other conditions. The cognitive symptoms and some of the mood-related symptoms overlap. So in the lab, we really look at symptoms and we try and figure out treatments for those symptoms, which means that if we do identify treatments, they can be applied to many different people. In the case of autism, now autism is not a psychiatric disorder, and certainly schizophrenia is debilitating, whereas autism is not. But they both share common neurodevelopmental origins. So in the case of autism, we're looking at inflammatory and stress biomarkers to try and see what is similar in regards to neurodevelopment in early life and identify what's different so that we can discover, for example, what might lead one person to go down the pathway of autism and another person, unfortunately, down the pathway towards schizophrenia. Okay,
and also I think there's some links and parallels with your research into cancer-related cognitive impairment.
Yeah, so we actually do quite a lot in looking at breast cancer, and you might think, well, what the hell has breast cancer got to do with schizophrenia? But actually cancer patients report high levels of cognitive symptoms that are very similar to some of the cognitive issues that individuals with schizophrenia have, as well as anxiety and depression comorbidities. Cancer allows us to look at a chronic inflammatory state and examine how the brain responds to inflammation as it increases in magnitude over time, because that tumor grows. So we're really using models of cancer to try to answer some fundamental questions about how the immune system and brain interact. And in fact, many of the inflammatory signatures and cells in the brain that we're seeing in regards to cancer is what Cyndi sees in postmortem brains of individuals with schizophrenia. But here's a really cool part. Some of the pathways we're looking in the brain are also what cancer biologists are looking in cancer labs at the tumor microenvironment, and they're developing drugs to target those. So it just so happens that we may be able to co-opt those trials and see whether or not available drugs being tested might be able to be repurposed for questions that we have in the schizophrenia clinic.
And obviously, I guess the benefits of that repurposing, Cyndi touched on this as well, right, of existing treatments is that you get a much quicker delivery, right, to the consumer market where it's needed than if you're inventing a new drug from a novel target.
Yeah, so I think that, new drugs that might be able to target and encapsulate the entire syndrome are the holy grail. But there are, as I mentioned, symptoms that we can target, and we can use available drugs potentially and repurpose those to help people now improve quality of life. There will be things potentially that available tools in the toolkit don't address, but this provides us with an opportunity of making some improvement much more rapidly.
Yeah, understood. Thank you. Well, that's a bit of optimism at least. So talking about symptoms, now it's my pleasure to move on to introduce Associate Professor Julia Lappin at the School of Psychiatry at the University of New South Wales. Julia is a clinician and researcher with experience in psychotic illness. She's the clinical director of the New South Wales Tertiary Referral Service for Psychosis which is hosted by Southeastern Sydney Local Health District at the Prince of Wales Hospital, right next door to Neura in Sydney. Julia, I know you believe it is critical to support the sort of basic research into underlying causes, which both Cyndi and Adam undertake, although of course it's a misnomer because it's not really basic at all, as people have heard. But you're also keen on research to improve quality of life for people with schizophrenia and their families. What have you found that works?
Thanks, Carole, and hello, everyone. Well, as we've talked about so far, schizophrenia is a very complex issue and causes a lot of difficulties for the people who experience it and also for those who are near and dear to them. We've talked a little bit already about pharmacological treatments, and as you've acknowledged, Carole, we know that there haven't been significant advances in the effectiveness of treatments for schizophrenia over the past many years. And that's not really for the want of trying, but there are difficulties in treating a disorder as complex as schizophrenia. And I think that we recognise that there are both biological and social determinants of schizophrenia and maintaining and perpetuating factors which also impact on the way that people can respond to treatments. So we know that antipsychotic treatments work, and they're the mainstay of our approach to trying to help reduce the distress that people experience through symptoms of psychosis like hearing voices or feeling that people are against them, feeling people are out to harm them. Those are what we call persecutory delusions, and we know that antipsychotics are some way effective in reducing both the symptoms and the distress that they cause. But there are other significant symptoms of schizophrenia that aren't targeted by antipsychotics, and those are really negative symptoms, which is where we see the absence of a behaviour which we might expect to see. So, for example, some people can lose the ability to enjoy things, lose motivation to do things, lose energy, lose interest in social and intimate relationships. We don't really have good targets for those treatments, for those symptoms. And then the other key symptom which many people with schizophrenia experience is the cognitive symptoms that Cyndi and Adam have already talked about. Again, antipsychotics we know don't really help with those symptoms, but we do have other treatments which can assist with cognitive symptoms really quite dramatically, and those are psychosocial treatments, and one in particular that we're rolling out through the Tertiary Referral Service for Psychosis is a treatment called cognitive remediation therapy. And that helps people to get back some of their thinking processes through practice, and that's been shown, which is fantastic, to improve people's ability to function and do day-to-day tasks in daily life. So that's a really important additional treatment that we have available to us on top of pharmacology.
So do you call that CRT for short instead of CBT?
That's right. So CRT, cognitive remediation, that targets the cognitive symptoms. CBT is another really important treatment, cognitive behavioural therapy, where people learn to identify whether their experiences are real or symptoms of their illness, and then to manage those symptoms and the associated stress and anxiety that they have with them. And CBT for psychosis is a specialised intervention developed to help people with psychotic symptoms, and there's a lot of evidence coming from the UK and internationally that is another additional treatment that can help people over and above antipsychotics. And that's something that we'd really like to have more available here in Australia, helping people to manage and master, take control of their voices so that they no longer feel that they are at the bidding of sometimes very hostile and terrorizing voices.
That would be terrific. If we move back up the pipeline of development of schizophrenia, is there work going on to identify people at high risk early? And can we then stop them progressing to worse disease?
Well, wouldn't that be wonderful? That's what we would all really like to be able to do, to eliminate this distressing disorder. There certainly is a lot of research in this field. It's exciting, and it's hopeful that we might be able, at some point in the future, be able to prevent schizophrenia and psychotic illness more generally. That said, it's not straightforward. So the way that people who may be at increased risk for the later development of a schizophrenia illness are detected is really by three main factors. First of all, they may have genetic or familial risk. Someone else, many people indeed in their family, that may increase their risk of someone else developing schizophrenia. So that's one group. Another group might be people who experience short-lived psychotic symptoms, for example, in the context of substance use. Someone might use cannabis or methamphetamine and experience psychotic symptoms for 3 or 4 days, and they resolve. Now, that person may or may not go on to develop a schizophrenia or psychotic illness, but they could be at least deemed to be vulnerable to the future development of psychosis. So that's another at-risk group. And then the third at-risk group are people who in day-to-day life might have symptoms of psychosis, but at really quite a low level. So for example, someone might hear their voice being called in the street, but only once a week or once a month. And these experiences are very common. You know, every now and again that happens to me, or I hear my phone go and actually there hasn't been a call. So these experiences do happen quite a lot in the general population, but at very low frequency, and generally tend to be dismissed and are not a concern. When they start to happen a little bit more often and people start to develop ideas around them, we think that's how in some people there may be progression into a psychotic illness. And so I've summarised those three groups of clinical high risk groups in whom a lot of research is being initiated in order to try and track their progression and try and understand to what extent we could prevent or delay later transition to schizophrenia. But importantly, many of those people might never have gone on to develop schizophrenia, and we do not actually know for certain that interventions, for example, CBT or antidepressants or mood monitoring or symptom monitoring, while they may be helpful, we don't know for certain that they do delay or prevent later development of psychosis.
Okay, fascinating. I mean, the more we talk about this, the clearer it is that there are so many different pathways to take, and they really need to be individualized, you know, to the person. But lastly, Julia, can you tell us a bit about the Tertiary Referral Service in New South Wales?
Thanks, Carole. Yes, I'd be delighted. So the Tertiary Referral Service for Psychosis is a new service for New South Wales, and we offer assessment and treatment recommendations for people living with complex and difficult to treat psychosis. So that's psychosis defined quite broadly. Many people have difficulties either right from onset or down the track, in that their symptoms persist despite their continuing to take treatment. Other people may have significant comorbidities, by which I mean that they have additional problems, for example, substance use or epilepsy or other difficulties, which mean that life has just become very difficult, and they're not tracking very well in managing and living with the distress that's caused by experiencing psychotic symptoms. And so what we hope to do is to offer the opportunity for second opinion and also treatment recommendations for people who are currently under the care of public mental health services. And what we're trying to do is not only help individuals, but also their carers and their families, and also referring services. What we're trying to, the broad scope, the sort of 5-year plan is that what we can actually do is increase the bar of the level of care that people can expect to receive clinically in New South Wales for the treatment of complex or difficult to treat psychosis.
Thank you. And I know obviously we have audience members from outside of New South Wales, but perhaps at least in New South Wales that can provide a model, and maybe over time it can be rolled out. And I think in our follow-up email, we're going to provide a link to more information about that service. Thank you, Julia. It's now time to take questions from our audience, and I'll direct each question to a particular panelist. They've been coming in as we've been talking. Cyndi, there's a whole bunch of questions for you around the inflammation matter, if you like, or issue. I'll try and group them a little bit. How do you identify patients that have this inflammation? And is that the same inflammation as in arthritis?
Okay, that's a good question. So the way that we're identifying people with schizophrenia and high inflammation is to use a combination of molecular markers, so biological markers. And we can measure them in the blood, but we can also measure them in the brain. So in living people, we're using the blood, and we're measuring the molecules that are made by immune cells. Most importantly, IL-6 seems to be a key factor, CRP, but we can't use C-reactive protein alone to mark those with inflammation, because it's a combination of markers, IL-6, IL-8, TNF-alpha, and we use an approach where we're looking at a combination of those markers to define who's inflamed. And right now, we don't know if that's the be-all, end-all of or the best markers, and we don't make a cutoff exactly. We do it by looking in dimensional space and identifying those that are high inflammation, but we want to know what else characterizes those individuals. And so we're looking at things like complement and other things that immune cells secrete to better identify those that are in that group. And when I say high inflammation, I don't mean like infectious, highly infectious disease levels. This is a low level chronic inflammation that I'm I am calling it high inflammation. I'm terming it that. And in that way, I guess it relates a little bit to arthritis in that there's a chronic ongoing inflammation. And in the case of arthritis, would be in the joints. In the case of schizophrenia, we think it's in the brain, but it is detectable in the blood in both cases.
Yeah, so you're seeing in the future perhaps a simple blood test?
Yeah, well, maybe a complicated blood test, but once we know the markers, you could imagine that, yeah, a simple tube of blood could help identify those individuals that are of the high inflammatory biotype, if you will.
Okay, I'm going to stick with you for a moment, because I know you and I have spoken about this, and there's a bunch of questions also, I guess, around the inherited, risks of schizophrenia, and also sort of age of onset. So questions such as, does schizophrenia run in families, and have you looked at hormonal changes influencing schizophrenia?
So the short answer is yes and yes. So yes, schizophrenia definitely runs in families, but even when you know all the genes, you only can predict with 50% accuracy. So like flipping a coin. So two people, identical twins, one has it, it's a 50% chance that the other one has it. So that tells us there's also a significant environmental component, whether that's inflammation early in life, in utero, or in children, or whether there's psychosocial stress or increased drugs of abuse at the time of onset, or increased hormones that then triggers a hyperdopaminergia, or perhaps a perfect storm, or different combinations of factors in different people. But it does converge in terms of the most common age of onset is in adolescence. And in terms of hormones, we knew that estrogen was protective, and that was the basis of launching our clinical trial with a selective estrogen receptor modulator, where we saw benefit in both men and women. But we are now looking at this in kind of an opposite way, that testosterone actually could be a trigger for schizophrenia, and we're doing studies on that.
And it's more common in boys, right?
Yeah, males tend to get it earlier on, and they end up having a more severe case, and they're less treatment responsive typically. So the incidence is like 3 out of every 5 individuals with schizophrenia are male. So it's not exclusive to males. It's just the males get it earlier and a bit more severely.
Yeah, I remember you telling me about that book, Hidden Valley Road, where there's a I think, a family of 10 or something like that, and 6 of them are boys, and they all had schizophrenia.
Yeah, that's an amazing story from a USA family in Colorado. I believe there's 12 kids, 10 boys, 6 with schizophrenia. Yeah, and yeah, that's a book that I'm actually recommending people read, and that we could maybe discuss next year together.
Okay, thank you. Adam, I'll throw this one to you. If it doesn't belong to you, tell me. Can schizophrenia syndrome now be classified as an autoimmune disease?
Well, I mean, Cyndi touched on it with the around arthritis. So that's certainly both autoimmune. That is an autoimmune disease. I suppose we don't know yet. Cyndi might have some ideas on this. Possibly, it is possible that the brain's inflaming itself in the body, but at this stage, we also don't know whether or not there may be some unknown pathogens. And Cyndi, I know, has done a little bit on this.
Cyndi, do you want to comment as well?
Yeah, so a couple of things about this. First of all, we know that there's a form of schizophrenia that's triggered by autoantibodies, and that's to the NMDA receptor. It was only discovered in 2006. So before that time, an individual could get the diagnosis of schizophrenia, but their underlying cause could have been brain autoantibodies. And as we know more about brain autoantibodies, the potential autoantibodies is expanding. So that's one thing that we want to look at. And the other thing, we can find antibodies in the brain. So not just in the blood vessel again, but in the parenchyma. And while we don't find overall any difference in the levels of antibodies within the brains of people with schizophrenia, we can see that the antibody receptor that's linked to pro-inflammatory cascades is markedly upregulated. So, you know, in the brains of people with schizophrenia, we've got macrophages, cytokines, complement, antibodies, all these things that suggest essentially an ongoing infection. So whether there's actually a microbe there or whether it's just mimicking an ongoing infection, in either case, it could be damaging for neural function.
Thank you. Adam, I'll come back to you. Is there any evidence to suggest that depression with psychotic features is a risk factor for schizophrenia? Does that link exist?
So possibly Julia is better to talk to clinical symptoms.
Okay, Julia, sorry.
That's no problem. So I think it's probably helpful to understand that when we talk about psychosis, it's quite useful to think of psychosis as being an umbrella term within which there are different ways that people can present, and that's really according to how their symptoms look and feel. So with schizophrenia, we see predominantly that people would hear voices and that they may have persecutory ideas, which is that they feel that they may be at risk of harm or that other people are against them, or they have a feeling of suspiciousness and fearfulness. With psychotic depression, which again is under that umbrella of psychosis, there are psychotic symptoms that might be hearing voices or believing that your body's rotting or believing that you're responsible for many bad things in the world. But there's also a really prominent low mood component. And that's why, on balance, the psychotic symptoms together with the very strong depressive symptoms mean that a diagnosis of psychotic depression is favoured over one of schizophrenia. But of course, as Adam mentioned earlier, there's a lot of overlap. There's schizophrenia and depressive symptoms. And probably it's most helpful for us to think about what are the symptoms that people are experiencing and how can we help them with those. So when someone who has voices, we try and help them with the voices, and someone who has cognitive symptoms, we support them with that through cognitive remediation therapy. Someone who has depression, we suggest talking therapy and perhaps an antidepressant.
I remember I discussed that with you in terms of, you know, as a clinician, how do you approach a situation like this where, you know, there are so many different pathways, people experience it so differently, etc. And I remember you saying to me, well, I start with the symptoms that they're experiencing at the time, and that's what I focus on.
That's right. And the things that are problematic for them. So some people actually can have relationships with their voices which are benign or sometimes even pleasant. And in that case, they might not be seeking treatment. and that's fine. It's when there's distress and deterioration and the impact on life that we should be offering treatment for those symptoms.
Yes. Another one for you while I'm with you. Question here about what do you think about social skills training? Is it more useful than CRT, or should they be done together?
Well, that's a great question. It depends. Again, let's just bring it back to what are the difficulties that the individual person is having. If the problems are particularly with social withdrawal, social anxiety, lack of connectedness with others, then social skills training would be indicated in those situations. If the main driver for social exclusion is that you can't work your way to get to the bus stop and work out which bus it is to get you to a social occasion, then that's an example of where cognitive difficulties are impacting on your ability to participate in social activities. And in that case, I'd say, well, CRT, the cognitive remediation therapy, is the right treatment there for the cognitive symptom.
Okay, understood.
And have both, just to follow up on Carole, sorry,
No,
just
that's fine.
the idea, could both be beneficial? Yes, and indeed we know that in people who receive cognitive remediation therapy, if they're also given quite intensive rehabilitation, they have a much greater chance of getting back into employment, whether paid or otherwise. And I think we do need to think about how we provide steps towards enabling people to get back into function. So just one standalone treatment may be helpful, but how far does it get us down the road to where we're trying to get to?
Yeah, I have one more for you that's just come in. This is a good question, I think. Just a bit of advice. If someone with schizophrenia is telling you about their delusions, what's the best way to handle or respond to that conversation?
Yeah, and this is a really key and important question. So thank you for the question. I think it's important for everyone affected by someone developing a psychotic illness to get what we call psychoeducation around what it means to have psychotic symptoms, what it means to have delusions and to be hearing voices. And then the next step is, how do we cope? How do we talk to the person about it? First of all, it's really good if someone is able to talk to you about what they're experiencing, rather than holding it all in and you simply not knowing what's going on for them. So I would say, as a first thing, I'd be sort of pleased that someone's able to talk about it. It's important, and this is a difficult line to walk, but it's important not to collude too much in someone's delusions, because then actually that just leads to them becoming more and more invested in it. And they may seek your confirmation, like, you know, did you see that just now? Or, you know, that person thinks this, you think that too, don't you? If you endorse that, that actually helps them hold on to that belief. So you don't want to do that, but at the same time, just to dismiss it and say, that's utter rubbish, that's not helpful either. So normally you try and walk, and I know it's easier said than done. Normally you try and just walk a fairly benign road and say, oh, I'm sorry that it's feeling like that. Why don't we go and do something to get our minds off it? So distraction techniques are helpful. You want to be non-judgmental. You do not want to sort of aggravate them and increase their stress and anxiety. So usually a sort of acknowledgement of what they've said without endorsing, and then a distraction would be a good approach, I think. And also to seek help from a psychologist, CBT for psychosis, for example, and work as a family member with the psychologist as well, get advice from them too.
Where do you find somebody that can offer CBT for psychosis? That's another question.
that there is a real lack of access to skilled therapists in Australia, and it's actually one of the things that we're hoping to make possible through the Tertiary Referral Service for Psychosis, is to try and get psychologists really excited again about working with people with psychotic illness, and coming on board and joining and helping us find ways to help reduce the distress that people suffer. So there are some specialists. You would need for that to go on the internet and look up, CBT for psychosis specifically. Depends also which area of Australia you're in. But we very much hope that access to trained therapists will become more available over years.
All right, thank you. Cyndi, I'm going to throw back to you in our last couple of minutes. We may go over a couple of minutes, but that's fine. There's a couple of questions here around the role of dopamine. So excessive dopamine is a cause of psychosis. Are your findings about immune cells in the brain discrediting the dopamine theory?
Absolutely not. So what's interesting is we first identified inflammation in the brain in the prefrontal cortex. And then, of course, we looked where the home of the dopaminergic neurons are, and we found more profound inflammation near the cell bodies of the dopaminergic neurons. So we think they're under siege, in fact, and the inflammation, like cytokines, is known to trigger dopamine release. So they actually could be very much intertwined instead of being separate. I think they're part of the same pathophysiology, in fact.
Okay, and another one about the role of vitamin D.
So that's the work largely of John McGraw and Daryl Isles. And so together they've looked at the epidemiology. So low vitamin D is a risk, low vitamin D in pregnancy. And certainly they have found that can lead to increased dopaminergic tone in the offspring by looking in basic studies in animals. So we actually haven't looked at vitamin D, but what's interesting about vitamin D is it can actually impact the immune system as well. So of course, that would be something that we would want to look at in people with schizophrenia and find out, does that add value to defining those that are in inflammatory state or maybe at risk for inflammation? So very interesting point. Certainly a lot of work cut out for us, but we want to keep expanding our biological repertoire to really understand the underpinnings, and there may be multiple, of why people are inflamed.
Yeah, it goes to the heart of what we mentioned before about basic research isn't really basic and is absolutely fundamental to arriving at new treatments and better management of the condition. Adam, I've got one last one for you. I hope this is right for you. Can you have both schizophrenia and autism at the same time?
Sure. Yeah. I mean, yes, it is possible. They're not. I didn't mean to suggest that they might be mutually exclusive. Our investigations are really looking at inflammatory markers and seeing if there are subpopulations, as Cyndi is doing in inflammation with schizophrenia, and identifying what's similar in children with autism to give us insights into some of those early neurodevelopmental processes that overlap. So as opposed to the end result and diagnostic differences.
Okay, thank you. This last one isn't a question, it's a comment, but I'll just read it out. Thank you to the presenters for all the hard work you're doing in this very challenging and unfortunately underfunded field of medicine. Sharing your knowledge today is much appreciated. Thank you for the comment. And thank you to all our panelists. At this point, I think it's my role to wrap up this fourth webinar in our series of NeuRAtalks. Please join me in thanking Cyndi, Adam, and Julia for sharing their expertise. And my thanks to you for your engagement and input. Look out for your follow-up email, and I hope to see you again in 2022 for NeuRAtalks. All the very best for the festive season from all of us at Neura. Bye-bye.
And thanks, Carole.
You're welcome.